Hello and welcome. We are back, TIF Talk Tuesdays. I'm Andrea Millers. Thank you for joining us. I'm with Endogastric Solutions. And today I've got some special guests. First off, I've got Wendy Prophet, who is here with us. She is also from Endogastric Solutions. And we have Dr. Goldberg, which I will be explaining or going over his bio in a second, but we have Dr. Goldberg and his patient Tina with us today. So welcome to the both of you and thank you for joining us today. So TIF Talk Tuesdays, before we start anything, I do want to remind everyone this is live. So at any time, if you have any questions, please feel free to type your question in the chat section and we'll do our best to answer all of your questions. You can ask Dr. Goldberg any questions and you can even ask Tina any questions if you have any. So before we start, I do want to give you a background on Dr. Goldberg. Dr. Keith Goldberg is board certified by the American Board of Surgery and is a fellow of the American College of Surgeons. He has practice locations in Springfield, Clarksville, and Hendersonville, Tennessee. Dr. Goldberg has advanced training in general, vascular, and laparoscopic surgery, and his clinical interests include robotic and minimally invasive procedures such as the TIF procedure for reflux, which we will be talking about today. And then we've got Tina Eden, who is also here with us, and she is Dr. Goldberg's patient. She actually had the TIF procedure performed back in July 2019. So we'll be able to dive in a little bit more and hear her story. And then you guys can ask her any questions that you may have. So again, a warm welcome to you, Dr. Goldberg and Tina, and thank you for being here with us today.
Thank you.
Awesome. So let's go ahead and start, Dr. Goldberg. I will go ahead and let you kind of explain what is GERD. What could patients potentially feel if they were suffering from GERD or having symptoms?
Sure. Thank you, Andrea. So GERD, gastroesophageal reflux disease, multiple possible symptoms. So essentially this means that the acid content or contents of your stomach are refluxing back up into your esophagus. Most people think of this as heartburn symptoms, but there are many others. We see a lot of patients who not only have heartburn, they can have chest pain that they mistake for a heart attack. They can have regurgitation, so patients may not be able to sleep late at night and food contents or acid come back up into their throat, which can lead to even aspirating or breathing that in and getting pneumonias. So that's the basic gist of GERD. Again, there are a whole slew of different symptoms related to it potentially.
Perfect. Thank you, Dr. Goldberg. And then Tina, when did you first start having symptoms? I know you have a very unique story. You just kind of briefed me a little bit before we started, but tell us a little bit about that and the story about your sister.
I actually do not remember a time where I did not have acid issues. Like Dr. Goldberg was saying with the regurgitation, I couldn't sleep at night. 3, 4, sometimes 5 and 6 times a night. I would be up vomiting. It was affecting my sleep, my husband's sleep, because I would be up with everything coming back up so much. When me and my sister were actually little, we were at Vanderbilt Children's Hospital, and they actually were doing studies on us trying to figure out what was wrong with our stomachs, because everything that they knew of that it could be, they would do the treatments and nothing would work. So I honestly don't remember a time, probably from the time I was 5, 6 years old, that I didn't have acid issues.
And then when did you actually get diagnosed with GERD?
I think I was about 19 when they actually said, okay, this is what we think is wrong with you. Let's try this and the diet change and see how things go.
Wow. Yeah. So Dr. Goldberg, she suffered for many years, and, there's things that people can do to kind of manage those kind of initial acid reflux GERD symptoms. What are your recommendations for, even before going to medical therapy and or potentially procedures? What do you typically recommend patients to do if they are suffering from GERD?
Sure. Well, unfortunately, I see patients very late in the game, and a lot of people like Tina, and they've been through all those things. But, we always start out with, First, the diet. So small meals frequently, not overeating, not having seconds, eating during the day, not late at night, not after 6 p.m. Avoiding trigger foods. Now, most patients know what their trigger foods may be. It may be tomato sauce, it may be orange juice. And again, most of them have selected those out. By the time they get to me and other physicians, they're already coming in saying, oh, yeah, I can't eat tomato sauce ever. I can't eat this. I can't eat that. So that's the first thing. Lifestyle, good, healthy lifestyle, moderate exercise, weight loss if possible. We talk about things, for people like Tina who can't sleep at night, elevating the head of bed, which is not easy, right? I mean, most people aren't able to do that. They tell me they're sleeping on 3 or 4 pillows, but by the time morning comes, those pillows are all over the place and you're flat again. So those are kind of the basic tenets that people try themselves, and we always start with.
Yeah, thank you. And Tina, were there specific things that you did? And I know they probably prescribed you with PPIs once they diagnosed you with GERD. Is that what happened?
Yes, I believe it. I think I've taken all the PPIs that they came out with. We had special block risers we bought that went under the head of the bed just to try to elevate the bed. They said lose weight. I lost 60 something pounds, still no changes. It still just kept going. Nothing was improving. I literally think I did everything. At one point, I was living off of cream potatoes because that was one thing that just seemed like it stayed down a little bit better and didn't cause as much pain and discomfort.
Yeah, thank you. So, Dr. Goldberg, it is National Cancer Prevention Month, and I know there's not a direct correlation with GERD to cancer, but maybe you could talk a little bit about what happens with untreated GERD as it progresses.
Sure. And there is a correlation between chronic gastroesophageal reflux disease and changes that can become what's called Barrett's esophagus that can lead to esophageal cancer. Really one of the worst cancers you can have, horrible prognosis. So we can really catch that at the beginning. And what happens is really the esophagus, after it's exposed to acid, it gets burned, it gets damaged, it tries to heal, and it's trying to do its best, and so it converts over to a different cell. This cell we label as Barrett's esophagus. It's more similar to your intestine cells that can handle acid. Unfortunately, that change can also come with mistakes eventually, and those cells can degenerate and convert into dysplastic or abnormal cells that can lead to esophageal cancer. So we see it, and it's really frustrating to see folks, not being aggressively treated for their Barrett's esophagus.
Yeah, so I think maybe you can kind of give a takeaway from that. What is the most important thing for patients to do? Because for colon cancer, right, you get colon cancer screenings, but typically right now there's no actual yearly screening that you need to do to determine if that is the case. Is that correct?
Right. No, that is the case. In fact, there are a number of articles suggest, folks shouldn't have routine upper endoscopies. But in patients who have chronic reflux disease, chronic heartburn that they know, people like Tina that were taking PPIs or medications for 10 years or more, even if they're young, they should have at least an upper endoscopy. That is the only way at this point that we can reliably diagnose Barrett's esophagus. So family history of things like esophageal cancer, hiatal hernias, family history of Barrett's esophagus, but most importantly, if you have chronic heartburn or reflux, 5-10 years certainly, you need to see someone, and you need to have an upper endoscopy to see what sort of damage and what the anatomy looks like.
Perfect. Thank you. And before we keep going, I do see a lot of questions popping up, so we'll go ahead and get to a couple of questions before we continue. Wendy.
Thanks, Andrea. So we have actually several medication questions coming in, Dr. Goldberg. We have John who is asking, I'm going to give you a couple of different ones, and maybe you can kind of funnel these all into one answer. John is asking, how long can someone stay on PPI medications, and are there any risks? And then Victor actually is stating that he has had acid reflux for over 20 years and now is taking Dexilant. Is this good that I have to take this all the time? I've tried everything, this is the last thing. And what is next in his option pool, I guess, is really what he's asking. And then Lynn is asking, can GERD ever go away on its own?
Okay. Let me go backwards on those and say GERD generally doesn't go on. Now, if you do some of those modifications we talked about, let's say you lost 60 pounds, yes, if you modify your diet and lifestyle, your symptoms can be controlled and your symptoms can go away. But that's really the exception, not the rule. In regards to the medications, so some 80 million patients are on omeprazole in this country or something similar, Dexilant, pantoprazole, all similar to that proton pump inhibitor. It's really FDA approved for short courses, but ultimately, because there have been limited options over the years, patients are on them for years, 20, 30, 40, 50 years at a time, and most patients don't realize there are other options. It's really probably not good to be on those medicines for that long. That being said, if someone's on a low-dose proton pump inhibitor and they are happy, perfectly comfortable, not complaining, I tell them, there are risks, but it's probably reasonable for them to continue that if they're comfortable with the risks. What are the risks? Well, there are slight risks associated with proton pump inhibitors. Basically, I think of it this way. There's a reason we have acid in our stomach. It helps us digest our food. It helps us digest and absorb the minerals and vitamins. So without them specifically, there are things that are not going to be absorbed properly. We don't know who that affects. We don't know who's getting what. So we have iron deficiency anemia. You might have vitamin D or calcium deficiencies. And so you could end up with osteoporosis. For unexplained reasons, there are potential small increased risks of things like dementia and heart disease. We can't fully explain those. And there are some folks that necessarily, can be skeptical of some of those studies, but there are enough potential problems with that basic tenet that it's reasonable that if you want to get off of them, especially if the medicine's not taking care of your symptoms, we now have great options for that. I hope that answered most of those questions.
Excellent. Well, and just to tack on really quickly, Vicki is writing in saying that she's had GERD since she was 13 years old. So kind of sounds familiar, Tina, right?
Oh, yeah.
She says, I've taken all kinds of medications and I'm currently on omeprazole and working on losing weight. Right now, my dosage is 40 milligrams and she's looking to make sure that that's okay.
Yeah. Go ahead. I'm sorry.
Oh, I was going to actually ask Tina if she can tell us her story about her journey taking PPIs and how bad it progressed through the years, if you will, if you don't mind. And
yeah, I think I've taken every PPI that was out there on the market at the time. When I actually came to Dr. Goldberg, I was on omeprazole. I was maxed out. I was actually more than maxed out because I was taking about 4 a day. I was only prescribed 3 a day, but I was taking 4 a day. And the insurance company sent me a formal letter and said, we're only going to pay for your medication for 6 more months. You've been on the max dose for too long. And at this point, I think I had probably been on omeprazole specifically for about the last 6 years or so.
Wow, that's crazy. And let's a little bit more. Or did Dr. Goldberg, did you have another point that you wanted to make about the PPIs?
Well, I just think, in patients like Tina, it drives me crazy. It's absolutely absurd. And, I think, just for years, there are so many physicians that just throw those medicines at patients without even thinking about the potential risks and not understanding that this is an anatomy problem, that acid reflux is because of poor anatomy. It's not because of too much acid. And we have much better treatments now that we're going to talk about, of course.
Yeah, no, I love that. Thank you. Let's go ahead and talk about that now. What are the available treatment options for GERD, Dr. Goldberg?
So, of course, my favorite treatment and the only treatment of choice for me, other than the things we've talked about, if we can manage them, is TIF and repairing your hiatal hernia. So TIF is transoral incisionless fundoplication. It is an endoscopic procedure that we perform through the mouth with the esophagus Z plus device. I generally combine that with repairing your hiatal hernia. I find that gives my patients just the most definitive total repair with a very short recovery, still a very minimally invasive procedure.
Perfect, thank you. So Tina, maybe tell us a little bit what drew you to the TIF procedure, or what made you decide that that's something that you wanted to do?
Well, I kind of felt like I didn't have an option with my insurance telling me, hey, they're about to not give me any medicine. And even though it wasn't giving me full relief, at least it was giving me some relief. So I got the appointment with Dr. Goldberg. I actually got scared and was going to no show on him because I just freaked out. My son has a Nissen. I knew what that was like, and I knew I didn't want that, and I didn't know there was any other option. And my husband actually talked. He said, just go hear him out. You're not going to lose anything. Go see what he has to say. And then he got to talking about the TIF procedure, and I'm like, okay, wait a minute. I can do this. This is totally different than the Nissen. So we went ahead and started the additional stuff that he needed in order to be able to do the TIF.
Love that. So did you mention to Dr. Goldberg that you were nervous about the Nissen procedure when you came to him with your GERD symptoms?
Oh, yes, for sure. That the NIS just is something that scares me. Not that it's anything wrong with it at all. I just know how, I know how it was with my son, and he was an infant. And I think as an adult, I'm like, wow, this would be really way more recovery and a lot more difficult.
Yeah. Dr. Goldberg, is that common for patients to come in when they have, because when they come to you as a surgeon, I think to your point you said earlier, they come to you when they're just at their wit's end. It's just bad. And what other options aside from the TIF procedure? And she did mention the Nissen. Do you want to maybe talk about the differences of procedures?
You bet. So Nissen fundoplication is a stomach wrap. We wrap the top of the stomach, the fundus around the esophagus. It's a 360-degree wrap, so it's a complete wrap. And just as a point, most surgeons use a total of 3 sutures to perform that. And so it will stop acid reflux. And if you ask all the surgeons that perform Nissens, they all think their Nissens are perfect, but really the follow-up is poor. And studies show that patients, large percentages, have really serious side effects. So that Nissen, with that 360-degree wrap, some patients get really bloated, called gas bloat syndrome. They're miserable. They end up in the emergency room. There is no cure for it. Some patients can't swallow because it's just a little too tight. And so those are some of the biggest issues and problems with it that you generally don't get with the TIF procedure because it is a partial fundoplication. So both techniques fix the hiatal hernia the exact same, but we use a partial wrap that has anywhere from 20 to 40 sutures holding that in place, endoscopically placed. So it just can't slip. It can't go anywhere. And really, when you're done with it, it looks like a normal 15-year-old healthy patient's valve. It doesn't look beyond that. It really gets people back to a normal condition.
Wonderful. Thank you. Wonderful. Thank you. Let's talk about recovery from the TIF procedure. So, what would a patient typically expect after their TIF procedure, Dr. Goldberg? And then Tina, you can kind of give us your story and how it went.
So in combination, again, I'll say 98% of my patients, I do what we call now a concomitant TIF or a C-TIF, meaning, again, we fix your hiatal hernia laparoscopically. I use 5 1-centimeter little incisions with a little glue on them that don't delay anyone's recovery. Recovery, typically, about a week of some chest discomfort and shoulder blade discomfort, sometimes less, maybe 3 days. Patients can go back to work really within 2 or 3 days if it's normal office light activity. There are limitations that I provide for heavy activities. So someone who's doing heavy lifting, farming, electrician, that sort of thing. I really don't want them to do any heavy lifting for 4 to 6 weeks in that regard at least. But really at 6 weeks, they're released to do almost anything they want. They do have a liquid diet, a full liquid diet, pureed diet for 12 to 14 days initially, just because the area is very swollen. And then we transition to a soft diet and then do a regular diet over the next 4 weeks. Other than that, really, most patients, can drive within 2 or 3 days. I usually give patients, 2 days worth of pain medication if they need it. But most patients take 1 or 2 tablets, really an ibuprofen, Tylenol, that sort of thing will cover any discomfort that they have. I do see a lot of variability in the diet online when I look at social media posts. Really I tell patients full liquid, you don't have to be on clear liquids for 2 weeks. You can puree, you can have smoothies and shakes and protein drinks. I recommend small amounts frequently in that regard.
Excellent, Dr. Goldberg. I am going to take over. Andrea is having a technical issue. She'll be right back with us as soon as the connection allows. Want to go ahead and just jump into a couple more questions real quick. Number one from Jason, he is mentioning that his wife is a teacher and that her ENT physician says that her GERD is being caused by having to push her words out and talking really loud through a face mask all day. Her PPI meds that he put her on just are not quite working and doing the job. What would you suggest?
Well, I mean, that's a little complicated. If she doesn't have long-standing GERD, if it's really as a result now of our current situation, right, of the masks and that sort of thing, that is not typical, or it's not the typical presentation. So number one, I'd be cautious about just jumping into a procedure for her. I mean, I do think she probably, if it's been going on for 2 years now and doesn't see end in sight, she needs some additional testing. So probably an upper endoscopy, probably something called a Bravo pH probe or something similar to that, where we actually measure the acid reflux to really document if that's occurring. And that's a great test for her because you can wear this little monitor while you're teaching. And so you can really see, hey, is she really having acid reflux during this stressful, loud conversation through a mask, or is something else going on?
Excellent, thank you.
Yeah.
So just along those lines, can you talk a little bit about the testing that you typically use, just expand on that a bit. And then Tina, would love to hear your account of what that testing actually included for you to the best of your recollection and what you remember experiencing.
So my basic minimum workup, of course, is history and physical, and really finding out that the patient, if they have classic symptoms. So if everything really adds up, someone like Tina, who is just over and over, and you're just like, why has this person not had more treatment for? But the minimum basic workup is an upper endoscopy to look at the anatomy, look to see if there are any damage or changes from reflux, to measure any hiatal hernia. So that's number one. I like the Bravo if the patient can be off of their proton pump inhibitor. There are some other tests you can do if they can't be off of that. My only other mandatory test is what's called an esophagram. So that's basically an x-ray where you drink barium. And I just want to basically make sure that the peristalsis of the esophagus is normal. That is my main goal with that test. You can do some other tests which are really uncomfortable to measure that. But again, if my patient is not having trouble swallowing their food and they have a relatively normal esophagram or motility of the esophagus, that's it. Those kind of combination, the physical exam, the history, an endoscopy, and an esophagram are the bare minimum if it's a straightforward situation.
Well, thanks.
Welcome
so,
back,
Tina?
Andrea.
I'm sorry. It's the joys of working from home and internet connection being spotty. I apologize about that. I'm assuming you asked the great question of the diagnostic testing to determine whether or not someone has GERD. So thank you for that. And then were we able to hear kind of Tina's recovery story Perfect.
So and we were going to talk about actually her diagnostic workup story.
Perfect.
I had the EGD done, and the best I remember, I believe Dr. Goldberg actually could see the evidence of the acid from over the time and stuff in my esophagus, so I did not have to do the Bravo pH probe. I did, however, like he said, do the esophagram. And I remember it was fun because the radiologists, they come into the room while it's being performed, and you drink this stuff. And he had a student with him. He's like, now they're going to drink this. We're going to lay them down. He said, very, very rare, you're going to see acid come back up. He said, but we leave them laying down. I think it's like 30 seconds or something. And I drink my stuff and I lay down, and he goes, oh, wow, you never see this. And he was calling everybody in. He's like, look, her acid is automatically coming back up as soon as we lay her down. And really, that's all I remember, because mine was pretty straightforward. So I didn't have to do any of the other testing.
Wow.
Very good. Thank
That's
you.
great. Yeah, thank you.
Andrea, could I also, just because we have a lot of questions coming in, just
yes.
and they all seem to be following kind of the same topic. So Andrew, Stephanie, and let's see, I think we had one more. Sorry, I'm losing my track here, but basically we have questions about hiatal hernias coming in. So Andrew says, my doctor told me I need to have hernia surgery. I really don't want to do this. I would prefer simply to have the TIF. But then Stephanie is asking, how long do most hiatal hernia repairs last? If the hiatal hernia surgery returns, does the TIF fail?
Good questions. I guess that's directed at me.
Yes, sir.
So those are really good questions. The TIF device is FDA approved to be utilized with small hiatal hernias, so less than 2 centimeters. So a lot of the TIF data and patients that had what we call a straight TIF includes those patients. And those patients really over the first 4 years after that procedure, even if they had that little hiatal hernia, data would suggest about 80% of those patients will be able to stay off of their PPIs and have treatment of their reflux and regurgitation. I will say that, as a surgeon, 80% is great. I like 90, 95%. I love 100%, but we can't guarantee anything. And so I find that fixing even small hiatal hernias at the same time, I really prefer that because I don't want to have to come back and say, well, you're in the 20% maybe that it didn't work, and I don't want to have to come back later. It's just easier and more efficient, I believe, to do them both at the same time. So I believe in fixing that hiatal hernia. That's part of that anatomy problem. Not only is your esophagus up in the chest where it doesn't belong a little bit, but the diaphragm is loose. The whole hiatal hernia is from the esophageal hiatus, or the opening in the diaphragm. And so snugging that up around the esophagus, putting the esophagus back in its proper position, really allows for that TIF to really give, I'll say, near 100% immediate resolution of your symptoms. It is potentially a little bit more recovery with the laparoscopic incisions for the hiatal hernia, which is typical, but that's what I recommend. I think one of them asked, well, how long do these things last? That's also a challenge because hiatal hernias are just like any other hernia. It's a lot easier to repair a hernia, let's say at your belly button, where you can push things in and you can put a big old plastic patch behind there to decrease the risk of it coming back. Here we have an esophagus that goes through that opening, so it's much more challenging, and that's why you find, fewer surgeons that perform this procedure, and it's just a little more mysterious. So we all have different techniques to try to decrease the risk of that hernia coming back. I will say that larger hiatal hernias are more likely to recur. And yes, when your hernia comes back, you're more likely to have recurrence of your symptoms with or without a TIF.
Yeah, that's a good point. And the healing process, the recovery process is probably real important in that, right, Dr. Goldberg, in ensuring that you heal appropriately so you don't risk potentially getting that hernia back and or blowing out your TIF valve that you just beautifully created as well, right?
Right. No, absolutely. That 6-week period that most expert TIF surgeons recommend, is really by design, very traditional, and it's really, let's not strain that hernia repair. In particular, let's not strain the diaphragm. Let's not strain the TIF and the stomach and esophagus, and try to let them heal the best we can, without individualizing and knowing, who's going to heal sooner, or slower. So even after 6 weeks, I try to tell my patients, especially who don't have mandatory heavy lifting, the longer that they can withhold from that, the longer they can avoid bouncing around on a tractor or, a riding lawnmower, the longer they can avoid, just jerk lifting, 100 pounds in the gym, 200 pounds. They're more likely to have better success, but we can't prove that. So at 6 weeks, we all agree at that point, all bets are off.
Yeah, perfect. Wendy, was there more questions that came up?
We actually do have several. One relates to LPR and PPIs that have been prescribed but are not helping with that. Basically, it looks like Rochelle says that the PPIs are helping a bit with her chest pain, but there is gas that seems to be filling up to her ears and head, she says, with her chest pain. Is that a normal occurrence, and what do you suggest?
Yeah, I mean, it's a common occurrence. LPR, laryngopharyngeal reflux, means that your reflux, like Tina, is going all the way up through your esophagus and hitting the back of your throat or your vocal cords. So you can have hoarseness, you can have coughing, and it really does not matter how many PPIs you throw at that. Again, this is an anatomy problem. This is a reflux problem. And so those medicines are not going to generally solve that problem. I mean, on occasion, they might take away some patient symptoms, like you said, the chest pains. So she needs more diagnostic testing to confirm that, and she needs to repair her anatomy with either, again, potentially hiatal hernia repair, potentially a straight TIF or a concomitant TIF.
Thank you very much. Also, we have Simone asking if TIF should be considered to avoid taking PPIs on a regular basis.
So sure, that's the other end of the spectrum. I certainly have patients that come to me that just refuse. They don't want to take medication, and it's fair. Listen, you're 30 years old. Someone tells you to take omeprazole. Well, what's the end point there, right? I mean, you're going to be on omeprazole for 60 years, hopefully, or more. So, really, it's very appropriate for patients to look into that. And if they really don't want to be on those medicines for the potential long-term side effects, those are folks that certainly I see and talk about and take care of.
Very good. Thank you. Just one last one from Jason. In talking with his wife, talking with her doctor, he says most GERD surgeries fail, and he seems not to be a fan of surgery. What should she ask her doctor? He says it just seems odd.
Well, again, she has to make sure she's got the right diagnosis, right? So in order to have a procedure that works for you, you have to make sure that you do have documented acid reflux, that you're going to take care of the symptoms. And like I said, it's easier. The more severe the symptoms, patients who aren't being managed on omeprazole or similar medicines, then it's an easier leap for them to go with some sort of procedure. Now, if she's taking 20 milligrams of omeprazole, she's happy, she's fully controlled. I mean, I wouldn't push her. I would never push anyone to have a procedure if they're uncomfortable with it.
Very good. Thank you. Okay, Andrea, that's all I've got for right now.
Fantastic. So before we conclude for the evening, I don't, forgive me if you already asked Tina this, but how are you today? I know you had your procedure back in July of 2019. It's been over a year, almost 2 years, right? So tell us how you are today. How are you feeling today? Do you still take PPIs occasionally? What does your family or friends say? Your sister?
Well, my sisters. But yeah, I'm not gonna say I don't get heartburn. I mean, if I enjoy a meal a little too much and overeat, I might get a little bit of occasional heartburn. I I've not taken a PPI since then. Matter of fact, he told me to continue to take my medicine for the first 2 weeks after surgery. And I came to my appointment. He said, "How's everything going?" And I'm like, "Well, not good." And he's like, "Why?" And I'm like, "Because I keep forgetting to take my medicine." And he's like, "Well, then I don't think that's a problem at all." So, I mean,
Nice.
It is absolutely amazing. I would tell anybody that they should do it in a heartbeat. I wish he was doing it 15 years ago, because I would have had it done 15 years ago. Lord forbid if it was to come undone, I would have it again in a heartbeat, because it literally gave me a life that I didn't know I could have.
Wow. Wow. Well, that's enough said. Now, when's your sister getting her TIF then?
Oh, I don't know.
I'm just kidding. I'm just kidding. Oh, we'll do a two sisters get the TIF procedure, TIF talk.
Well, I do think, sorry to interrupt, I do think she did have a family member who had it.
Yes.
Oh, you do?
Ended up having it about 2 months later in the same year.
Wow. How's she doing?
She's doing great as well.
Fantastic. Well, you've got a fan club over there, Dr. Goldberg. Well, before we conclude, and I do want to express, and maybe Dr. Goldberg, you can give some final thoughts. The whole reason for these TIF Talks is really to educate patients or people that are looking for alternative solutions other than just continuing to take their PPIs or double dosing, and that did not know that there's another alternative than just doing the traditional Nissen procedure. So what would be your, let me ask Tina first. Tina, what would your advice be to these other patients that are suffering that are out there?
I tell people all the time, just go talk to him, because you're, like my husband told me, you're not losing anything by just going and talking to him, and you're gaining something that you never knew you could have. Life, and I know this might sound so crazy to people, but life literally changed for me, because I didn't have to worry about not being able to eat for 2 or 3 days because my stomach was so bad, or not being able to go out with friends and have dinner because they were going out at 8 or 9 o'clock at night, and I couldn't eat that late with the risk of not being sick for days on end. So I tell everybody, do your research, make sure you go to somebody you trust, and just go talk to them, because it's 100% worth it.
Love it. That's perfectly said. And Dr. Goldberg, any last comments or recommendations or advice?
Yeah, I would just tell patients, be cautious what you see on social media, talk to your doctor. But I will say this again, many physicians aren't familiar with all of the options. So you really need to seek out an expert in the TIF procedure specifically. Most of the physicians, GIs, surgeons that perform TIFs, they really are experts in what they do, and they'll give you lots of different advice and opportunities to ask questions.
I love that. Thank you so much. Well, I can't thank you both enough for joining us this evening and doing this TIF Talk, for everybody watching. And thank you for everybody who is engaged and asked a lot of questions. So if you are in the Tennessee area, Springfield, Nashville area, I would assume, you can go and visit Dr. Goldberg. But if you're not, there are physicians all across the nation, and you can go to gerdhelp.com. And on there is a physician finder, and you'll be able to either type in your zip code or state, and you'll be able to find a TIF trained physician near you. So again, thank you again. We started up TIF Talk Tuesdays, so every Tuesday you can catch us with another physician guest and patient. But thank you everyone for joining us this evening, and I hope you have a great evening. Thank you. Have a good night.